Hello and welcome to this episode of Community Voices UG on Civic Space TV. I am Philip Melissa. I want to welcome all of you to this episode, and this episode we want to take in attention to a subject rather so important to humanity, that is health, because indeed without good health or progressive health, none of us, indeed the entire world, can have anything to do or to say in terms of other sectors of what we call economics or the politics or the academics. It is the health that performs the bedrock role in terms of us being able to do all the other activities. I want to welcome you once again, and we are discussing the state of access to healthcare, but also later we discuss some of the unfolding events and anomalies in the institutionalization and activity and progressiveness of the healthcare system of our country, including conversations around medical interns, conversations around the hospitals, conversations around the ministry, and things relating to the health. And before we get into the depth of that conversation, I will give a minute to each of you to briefly talk to us about yourself, but also talk to us about your environment, where you are. You tell us where you are and what is, very attractive or intentional, or something you'd want us to know about the specific environment in which you are as we get into this conversation. I'm happy to have you, and for that introductory bit, I should start with, Mr. Ronald. Mr. Ronald, please unmute and talk to us about yourself and where you are.
Good morning, ladies and gentlemen. I'm called Goodluck Musings Ronald. I am a journalist and also an editor with Chigezi News, but with passion writing health stories. Currently, I am in Lila City, where the Minister of Health was launching the post starting from Monday. Thousands of people, other services is having a new tarmac from Kampala, from Kampala Road, as you enter the city, series of oil, cooking oil, and therefore I see it's a busy town that goes out throughout the night. It's quite interesting how come to again Guru and other places. So I've liked leader. I can have another trip here to just see what it is. People are friendly, even if it's hard. Sometimes they talk to me thinking I know the same language, and therefore people are very friendly. Thank you very much.
Thank you so much, Mr. Goodluck Musinguzi Ronald. One of the answers we had a lot in our lower levels of education in regards to the colonialists and earlier traders and missionaries was language barrier. We hope in the future we don't write history saying Ronald experienced language barrier in Lira, but thank you so much for being there, and we hope to see some of the work you produce from that particular area. Yes, we go to Miss Angela. Talk to us.
Good morning, everyone. My name is Nagawa. Okay. My name is Nagawa Helena Angela. I am an intern pharmacist at Mulago National Referral Hospital, and I'm happy to be here in this conversation. I'm passionate about sexual and reproductive health and healthcare in general. So currently, I'm rotating on the neuro ward in Mulago National Referral Hospital. And all I have to say is the workload is very overwhelming. The patients are very, very many since this is the National Referral Hospital. And we're trying our best, but we're very outnumbered as healthcare professionals. The healthcare professionals that we found, the doctors, the nurses, the pharmacists are very welcoming. They oriented us very, very well, took us around the place, they guided us. But we cannot underlook the fact that the patients are so many and the healthcare professionals are very, very few. Yeah, thank you.
Thank you, Miss Angela Nagawa. at the neuro ward in Mulago on duty. Wow, I don't know what to say about your location and what you are looking at as you have this conversation, but all the best through the conversation, but also the activity you're undertaking there at the National Referral Hospital. Thank you so much for joining us. The other gentleman, Mr. Rikana, please talk to us. Yes, thank you so much, Dr. Rikana Ndaura, and it's so interesting that we have people who are directly in the healthcare system, and we shall have to feed so much into your knowledge, but also the experience you have and what you see yet to unfold in the same system of our country. Now, colleagues, as we get into the conversation, you and I might know that we're having the 10 days of awareness on postpartum hemorrhage, and Mosingu's good luck did mention that he's in Lira, where the minister is launching this particular activity. And when we talk about this postpartum hemorrhage, these are highly scientific, technical, terminologies that the ordinary person like myself might not easily associate with or understand. Since we have medics on the panel, they should indeed assist us in breaking this down to a layman like myself. I should start with you, Dr. Ndaura. When I listen to postpartum hemorrhage, that takes me back to my high school where my biology teacher was saying a couple of things here and there, and I'd be like, oh, now, what is that one? What is the other one? So help us understand, what is this postpartum hemorrhage? Technical challenges either with the network or with the machine, I cannot tell at the moment, but as we wait for him to join us once again, I should be talking to you. Mosinguzi, I hope you're with us. Is your network clear?
Yes, I'm fine. I'm able to hear you.
Yes, thank you. You did say you are in Lira, where the minister is launching the 10 days of awareness on postpartum hemorrhage, and I was trying to get from the doctor what it simply means in the layman's language, but you being a journalist and being in an environment where this is being discussed extensively, talk to us. What have you picked from this particular subject for the layman to understand and feed into their mind about this?
Thank you very much. I think simply PPH or postpartum hemorrhage means excessive bleeding after childbirth. And therefore, there's nothing else more than that. The ministry is saying that this is one of the highest killer part of what mothers are going through, because it's one thing when we take our mothers to hospitals or our wives or our sisters, girlfriends, and whatever, and then you hear they have died in the hospital. So when you ask what killed, people just say, she died. But the Ministry of Health is trying to aggregate to, they always put they always put investigations which are called confidential investigations that really tell what was the cause of death. And therefore, like 1 or 2 months ago, they carried awareness on PET, which is preeclampsia, eclampsia, preeclampsia, all that around that. That is pressure among pregnant women. But then this time around, they have come for the excessive bleeding after childbirth, so that they can really cause this awareness. And one of the things in the environment from Hoima, where the PS launched, the national, then here in Lango, also where the minister has had time to launch it again. First of all, it's an ongoing campaign. While they have dubbed it 10 days, but it will go throughout in this month. It's happening everywhere in the whole country. Now, the point for me as a journalist, what I can easily pick is that when our mothers, when they become pregnant, they make a choice between going to a hospital set up for antenatal, That's number one. But number two, do they have traditional birth attendants in their localities? Now, I have seen that where the biggest problem could be is that when a mother gives herself to a traditional birth attendant, while she might go the other side, she might they give these reasons like, when I go to a traditional birth attendant, they care, they prepare some tea for me. But the Ministry of Health is saying when you are attending antenatal, they have to classify you to see, are you a high risk mother? For example, they look at these things. Did you experience excessive the excess distension of the womb? Then they see, have you spent long hours in labor? Then they also look at, do you have enough blood, or did you have enough blood during your pregnancy? Then how about those who tend to use local herbs? I have seen this, if you have heard of a mumba, if you have heard of, there's too much advice flying away from the medical profession, like Helena and others. So you find that people now also, if you are carrying a twin pregnancy, then how about those who deliver at home? Have you had a C-section before? So these are mothers who are at risk, and after childbirth, it's not yet over. They have to give you, the ministry is saying you have to get 2, 3, 4 days being watched so that it doesn't happen, because most of the people say it's done, let's pack our things and leave the hospital. But then when they reach the other side and the bleeding starts, and that's why they are saying the theme has really been that every drop of blood, every minute counts. So, and you can imagine when blood is dropping in a minute, I don't think you need even 2, 3, 4 minutes to die. Thank you very much.
Thank you so much. Good luck for that comprehensive observation and pick from the activities of the Ministry of Health, and indeed what you learn from out there. Dr. Ndaura, do we have you? Yes, as Dr. Ndaura still works on his connection issues, I want to bring you in Nagawa Helena. Where you sit or where you work from now, as it stands, the Mulago Referral Hospital. Talk to us about what can we know about this PPH from your point of knowledge and expertise, but also what experiences have you looked at Mulago Hospital in relation to the same?
Thank you very much. I hope I can be heard.
Yes, you are. Maybe we can have your video on if it's okay.
Okay. Though it's a little busy here, I'm requesting that I can just speak. All right. So basically, like my colleague said, postpartum hemorrhage is excessive bleeding after childbirth. Yes. So we have two classes. There is primary postpartum hemorrhage and there is secondary postpartum hemorrhage. So when a mother bleeds within the first 24 hours after delivery, that is primary postpartum hemorrhage. So secondary postpartum hemorrhage occurs after, or when the mother bleeds after the first 24 hours, but again within 12 weeks. Yes, that is secondary. So there are so many risk factors that can potentially cause postpartum hemorrhage, that can potentially cause that kind of bleeding after childbirth. Yes. So we have cases of cesarean section, mothers who give birth by cesarean section, those who have prolonged labor, for those who have to be induced to give birth, that's induction of labor, for also those who have pregnancy complications like the large babies, the babies who are overweight, And also for those who go for the route of vacuum-assisted delivery, so many complications, yes, are all risk factors that can potentially cause excessive bleeding after childbirth. So as a pharmacist, from the management that we usually have, you have to first assess the cause and then you manage in accordance to the cause. Yes. So like I say, there's so many risk factors and so many causes, but the management of postpartum hemorrhage is in accordance to the cause of it. But usually, basically, we have to look at promoting the uterus to contract. And in there, we have drugs that we give. They're called uterotonics. They're usually given to induce that uterus to contract. So examples of these drugs, we have oxytocin, misoprostol, egometrin, carboprost, basically. But yes, in general, a postpartum hemorrhage is, yes, you have a question?
Yes, thank you so much. You mentioned those things, but specifically the causes. You mentioned a couple of them: prolonged labor. You talk about cesarean. You talk about overweight babies, and so on. Do you think our mothers and general across the country have this information? Know that actually this, if I have a prolonged labor period or cesarean section, I'm at risk of going through PPH, which could actually lead to my death. Are they aware? Do they have the information?
Well, just like any other society, everything is relative. You'll find people who are actually informed, and then you'll find those who are averagely informed, and then you'll find those who have no idea and are clueless. Yes. So Mulago is actually a very big hospital. You get all kinds of patients. Those who are actually informed are there. They come. So yes, I'll say that there are some mothers who come and they actually know that this is actually a risk factor for this. I could get this when this happens. Yes. But also, I would say that the majority may not necessarily have the accurate information or may have little or no information at all. Because like you tried to mention, postpartum hemorrhage is kind of a big word, yes? So you usually have to simplify these words. Yes, they may know that maybe they can bleed, but they do not know what causes the bleeding. They do not know how to go about the bleeding. You understand? But I would say that there is a percentage of patients who are actually very, very informed, but also the majority is on the other end of the equation.
Yes, thank you so much. I don't know whether we have Dr. Ndahora back. Doctor, do we have you back?
Yeah, apologies.
Yes. Thank you so much. Talk to us from your point of knowledge, and what can we know about PPH in your view, in layman terms, but also the causes. Helena here has talked about a series of things in line with causes, and how much of this information is available to us as a community, and from where you sit and all the people you know.
Okay, so thank you once again. PPH, or postpartum hemorrhage, simply means the bleeding that comes right after giving birth by a mother. So it's basically in two categories. There's the one immediately, that's just like right away start to bleed. When you give birth, when a woman gives birth, bleeding should stop immediately. It's one of those things we try to do to make sure they don't bleed. So when we say early or the primary postpartum hemorrhage, means it's just happening within a very few hours after giving birth. And then we have that is secondary, that usually comes after sometimes just 24 hours. So we get this mother bleeding again. Now, the rational causes, just one, the causes can be on us, the health workers, because we have things we do, what we call management of active stage of labor, the second stage. When a mother gives birth, there are some things we do to ensure that we stop this bleeding. Those who have given birth, like the mothers who have given birth, or those who have seen it happen, do things like uterus massage. We make sure the woman does not have any tear, what we call a rupture. And then we make sure that if there's any like C-section, we have crossed very well their uterus. So some of those things we do, and then we give the mitred drug Oxytocin, it's just a drug that is always available in all facilities that we give when a mother just pushed a baby. So we manage that stage. So as a health worker or in a local setting, what they call the basawo, when you don't do that, then the mother is going to breed. But then there are also other things that are beyond our control. That's nature can play its part. The other risk factors. And maybe I just want to go direct to your question because that's my area of interest. Do the mothers or do the communities know about these things? Now, Comrade Philip and the audience, one thing you must know, very few people in this country actually understand about the healthcare. When it comes to health education, very few people know these things. You can only verify that when you go online on things like Twitter, which are platforms that we think are for the elites. Simple topics are not understood by the people who represent those who have learned, who are learned. Remember, these things require some level of education. In places like Usoga, you'll find that a very small number of people have passed primary 6. A group of mothers of reproductive age, around 15 to 49 there, you find that they have gone to P6, and you hear the things I'm explaining. They are technical. Even when we have phones, when people Google, they are Googling other things. They don't look at these things. So where would be the platforms that people would get to know these things? One, antenatal care. We have a formalized structure under the Ministry of Health for all health facilities. Antenatal care. A mother is supposed to be seen by health workers at least 4 times. At least 4 times in a period of 9 months of pregnancy. At least 4 times, the bare minimum should be seen. During that time, we're actually not doing much. The things we are doing don't necessarily concern as what looking at the child or the mother or something. I mean, the fetus. But we want to take this time to educate the mothers on the key aspects of the complications in that this PPH. So what would we want to tell them? What PPH is, for example, what are the risk factors? What can they do? But you will find a mother, Comrade Philip, I've delivered mothers, and my colleagues who have been in a healthcare setting, or even the audience themselves. You receive a mother, they're in labor. In labor, it means they are about to give birth. Just they have few hours, minutes to give birth. And then they have never gone for antenatal care. So you wonder, the mother's been pregnant for 9 months, they have never gone for antenatal care. So where do you expect such a person to know this information from? And what can you do at that point? Can you start antenatal care? Can you start educating about PPH? So that's one of the challenge, and that's a platform where I would get these mothers educated. Now, 2, others go for a short time. So out of the 4, you'll go for 2 or 1. In this one, the health workers are doing other things we are supposed to do. Let's say testing, screening for your blood group, screening for syphilis. Okay, what we call risk factors that might hinder this pregnancy, so that we let the mother know. So we don't have this time to do the health education. That is part 2. Now, part 3, we are busy. We have very many mothers, so we want to focus on screening and doing the basic things that the mother should be done for when they have come for antenatal care, so that we prepare their child that is going to be born. So that's another side. We have few, so we don't have this person who will spare some time to waste to put another 1 minute or 30 minutes here to educate about this PPH. So this is a workforce issue. And then the last but not the least, some of the health workers do not have the capacity to explain these things adequately for the layman to understand. I would be surprised that even in a medical school, if you ask a professional to explain what PPH is in a local language, their local language, they will not know. English, they know the concepts very well, but putting them in their local context for the other day people is very, very hard. So that could be maybe a language barrier or just the language broke. They cannot put it forward. So those 4 hindrances are the ones that make this a problem. So to conclude, very few mothers know this. Very
Thank
few.
you.
Even the husband.
Thank you. And it's very painful when you say very few mothers know about it, yet it's one of the things that are claiming many lives for our mothers. Very, very painful. I want to go back to Musinguzi. Musinguzi, you being a journalist, but also you say you major in both reporting and writing. When you listen from the ground in the field, how much information, but also in what context do people talk about these circumstances, and how do you think you people in the media can play a role in trying to make sure our mothers, especially in the villages, are able to get this kind of information? And so I guess Mr. Musinguzi is having technical challenges. As we wait for him to return, I will go back to you, Miss Helen. I hope you're still with us. Earlier you talked about the primary and secondary, stages of this PPH. And one of the things you mentioned is in the secondary is it can go up to 12 weeks. You see, when you mention 12 weeks, these are 3 months. 3 months of someone being at the risk of experiencing PPH. How secure are our mothers, especially in the economics of this country that you know very well? People can't keep frequenting the medical facility every other day. People in the villages, after giving birth, some of the mothers are quickly into their workplace, in the markets, they're on the road, they're everywhere. How can these mothers who are struggling in our economy be protected from experiencing the secondary bit of the PPH that takes all that time?
I beg your pardon on the question, the last bit. I had everything else, but I didn't hear the last part.
Yes. The insurance, the protection of these mothers, because, the moment they leave the hospital, they rush to the garden, they rush to the market, they rush to the office, wherever they work from, and they are still at the risk of experiencing the secondary bit of the PPH. How can we protect them, prevent this from happening to them after them leaving the medical facility?
Oh, all right. Thank you very much for the question. So I'll speak from a pharmacist's point of view, because that's my specialty. So usually what we recommend weekly or bi-weekly reviews. Yes? We recommend that these mothers come back to a health facility that's nearest to them. Why? Because you need to check and assess for their vitals, the blood pressure, the heart rate, the oxygen saturation. Because whenever we talk about blood loss, all those factors come to play. They come to table. Yes. So we want to ascertain whether the blood pressure is actually still in check, the heart rate is still normal, whether the oxygen saturation is still okay. And that is usually done better at a health facility, especially for mothers in underserved communities or the villages. Yeah. Secondly, we always give them a counseling whereby we recommend that they eat green leafy vegetables. They should be they should take hibiscus, the hibiscus fruit or hibiscus tea. Sorry, the flowers. You can do hibiscus tea. You can do beetroot juice. Things that can be able to replenish your blood. Yes. Then also we can actually recommend that they have iron tablets or iron supplements. That there are some tablets in the facilities that we have for just to replenish their iron, because usually with loss of blood comes loss of iron. Yes, so that at least we keep their iron in check. And then usually also when they come back, whenever their vitals are assessed, we see the missing gaps. What is missing? Is there a trauma? Is there any infection? Is there a sepsis? How can it be managed? Do they need to be readmitted in the hospital for quite a while before they go back? Yes. But again, for me, what I recommend the most that is most sustainable in all this, even after recommending weekly reviews in hospital, monitoring of vitals, giving them iron supplements, telling them to eat fruits and leafy vegetables that can be able to replenish their blood. I think for me, the most sustainable solution and what is more important should be a continuous education. And to re-echo what Dr. Elikana said, it should be put into context of the mothers that come to the facilities. Because usually you'll find that in the city, this say, like, let me say Kampala, in the hospitals in the city, you may find that a good percentage of the mothers can actually ably speak English. They can ably construct sentences in English. But when you go to the villages, you have to put context. You have to be able to break down every particular term. You have to be able to break down the risks associated with that bleeding after childbirth. Yes, and what could potentially happen if the mothers are negligent, if they do not come for their reviews, what is going to happen? If blood is lost, in the simplest of terms, what is going to happen? You're telling them that they need iron supplements. Do they even understand what iron is and why they need the iron in their bodies? Yes. So for me, in as much as we have that kind of monitoring assessment and reviews and everything, what I recommend, because one thing for sure is these are mothers. Tomorrow they're going to give birth. Yes. The next generation is also going to learn from them. They're going to learn from what they know. So if we are able to empower these mothers with that information contextually, then I actually think we are going to be empowering the coming generations. Even when they give birth to daughters, when the daughters come, at least they have an idea or two about the risks associated with postpartum hemorrhage and what will happen to your body when you're not able to, when you do not consider going to the hospital, when you do not consider to do what the doctors are telling you. Yes, thank you.
Thank you, Helena. Before you go, for example, say you have a mother who left Mulago, had their delivery at Mulago, they traveled to Rukwanjiri or Bushenyi or Kitgum, and they have an issue maybe 1 week down the road. What are some of the ways these can be managed locally before they are transferred to the hospital? In other words, the kind of first aid one can be given before they are able to reach the medical facility.
For starters, I do not think a hospital can release a mother who is in a very dire situation. Yes, I don't think they would let that mother go unless the facilities, of course, are limited. But then again, in case it actually happens, there's a reason why hospitals work on referral points. Yes, the doctors will probably write for you a referral kind of note in accordance to the area where you're going. So where you're going, you'll be able to present that referral note from the doctors who have been managing you. That referral note will be clearly indicating what you're suffering from, maybe if it's primary or if it's secondary. Yes, how they've been managing you, and they'll also write a note on how you can be helped in that facility where you're going to. They'll probably refer you to the next one. But then I don't think they can actually release you if you're in a very dire situation, because the possibility of a bleeding mother, a mother who is, postpartum hemorrhage is not just bleeding, it's excessive bleeding. Yes, you cannot send that mother on a very long journey. It's very, very impossible. But usually the hospital works on a referral kind of basis, in that if a mother has to go and they've deemed it also wise that they can actually consider a few hours for them to travel, then they'll work on a referral kind of note.
Well, thank you. Dr. Ndaura, I want you to bring back, earlier you mentioned, you talked about something so critical. Our traditional midwives, the villages, there is someone at the banana plantation, and very many mothers have gone through that particular setting. There are actually many live kids and mothers who went through it, but also we've lost a number of them. What is the degree of risk of delivering through such mechanisms in terms of bringing about the PPH we are talking about, and what is the capacity of these traditional midwives in addressing the challenges that may arise in that particular setting?
Comrade, so for starters, I'm actually a product of a TBA. I was born by a traditional birth attendant somewhere in the village there. And I've seen many other my colleagues that were born this way. Okay, we survived our way out there, but the risk is so high, so high. One, straight away, is that being born in the hands of a non-skilled person shoots your risk so high, because remember, the maneuvers we do, what we call the management of third stage of labor. After giving birth, the maneuvers we do, one, we give oxytocin. Oxytocin is a drug. A traditional birth attendant cannot have oxytocin. Its primary work is to help the uterus. The Baganda call it Navan. they help the uterus to contract or to get back in shape so that the blood vessels reduce the rate at which they are oozing this blood. So it's a primary paramount mechanism support you. A TBA, a traditional birth attendant, does not have this, which means the mother will never get this. But they can do the uterine massage because that's manual. She can do that. She can also do some other maneuvers. But for example, if a mother gets a tear in this case, you maybe the child was big and the other parts have gotten torn. A traditional birth attendant cannot repair a tear because we have seen them bringing the mothers with very bad tears. And mind you, a mother needs not more than 30 minutes to die when they're having PPH. So just like
30 minutes.
Yes, just like how Miss Helena just told you, you don't have time to just waste on the Lord. You just have around 30 minutes to get blood out and then you die of shock. So we are at a very high risk. However, it doesn't have to be that it's only this unskilled labor, because there are other risk factors. So whether you are in a hospital or the other side, there are other factors which don't care whether you are with a traditional birth attendant or whether you are in a facility that has a health worker who is well trained. It's about someone noting that I am at risk, which means what is most important is to put these risks in the public for people to know who is at risk. That's what I want like a society to know who is at risk, so that if I know I'm at risk, then I prepare. Even for us, the health workers, you can easily prepare for a mother whom you know that they are at risk. It is easier that way. But being in the hands of a traditional birth attendant or a person who is not skilled increases your chances, because once you bleed, then you are likely going to get the worst state.
Thank you. And maybe, Doctor, briefly before I let you go, how can we discourage our mothers in the villages from, using this kind of mechanism and they opt for the medical facilities?
So the mechanism, the mode to discourage them is very simple. It's actually what colleagues in the ministry are trying to opt for. It's very simple. It's working with the community. Community has voices. The community can let you down if you do not want to cooperate with them. Remember, we have people who don't trust the systems. Because if someone has never gone for any antenatal, how do you expect them to now come to a hospital? If someone has had her two previous deliveries and have been successful with a traditional birth attendant, and has seen a neighbor who went to the hospital and came without a child, do you think they are likely to switch to the neighbor's side? So what we can do is working with the systems, engaging with the traditional birth attendants to empower them, for example, with the skills to know which mother can they manage and which mother can they not manage, so that we do what Ms. Helena Aya referred to as early referral. So if a mother comes and the traditional birth attendant is aware this one is a twin pregnancy, I cannot manage, we will be able to operate and say, Mama, you go to Kawempe, and you'll be worked on from there. So it is easier that way. But the moment we try to shy away from the traditional birth attendants so that we don't give them the respect they deserve, they will hide the cases and suffer with the mothers. That's one side. But also on the other side is that they will do things that are beyond their side, because she's going to fear to send the mother to Kawempe, because they will ask the mother who was working on you and they arrest her. So she will mess around with the mother until she dies, because she has just saved herself. you know. But if she knows that she's free to bring the mother to Kawempe at any point, then it will be easy for her to come. And maybe the other core point is the mothers themselves. As far as we educate this community, if the mothers know what to do, then they will not go to traditional birth attendant. Remember, the education, the method we use now, like we are on Civic TV. I know many mothers do not get it, but we have some churches in the community there. We have churches where we can spare a minute or two to talk about this. We have church TVs, which the ministry can invest in money and they do this education. We have traditional leaders who have powers. For example, if the Kabaka has spearheaded such a PPH campaign, the whole of Uganda would be sorted. If the Chabazinga got onto this track, the whole of Usoga would be just, if the Awich got into this, the West Nile would be sorted. And then back to the West, something of this kind. So we need this kind of engagements, because the most important thing is the mothers to know why we shouldn't do this and where should we go. What happens if we do this? That's the whole science. Once we do that, we can minimize this. And maybe the last one is economic empowerment. By the way, some people do not refuse to go to the hospitals, but the costs associated with going to the hospitals. Remember, a delivery in the traditional birth attendant, the rewards is like a chicken, just one chicken or some good bunch of matoke for some people. But when you come to Kawempe, for example, you will need transport, which is 20,000 for someone from Kampala. That is if you come on a border. And then you will need something like 50,000 to come from a place in Chisoro to go to maybe Mbarara Regional Referral Hospital or Mutorere, something of that kind. So there is a mother here who has not saved even 30,000 throughout all this time because has no support, has no husband maybe, and wants to deliver as well. So we look into this. Do we really have the money? So if I don't have, then I'm settling for less in my home. I'll give back. So if we empower these people economically, that's one side, through whatever means, whether parish model, whatever, whether circles, or told them to save early 2,000 each day, that would work. But also infrastructure, that's also empowerment. Because now the roads which make the transport expensive is because they are poor roads. If the roads have been made, the infrastructure, then the transport will be cheaper. Something of that kind.
Thank you. Thank you, Doctor. I don't know whether we have Good Luck back. I wanted to briefly, Good Luck, do we have you back?
I'm on.
Just briefly as we conclude on this topic, talk to me, the role of the media in trying to see that our mothers across the country are able to have this kind of information such that they don't become victims of the same. Yet, if they had known, they would have behaved differently, gone for antenatal and managed better to see that they survive. What is the role of the media and how much is the media doing to see that this information is available to the people?
Thank you very much. I think, first of all, the media needs to be taught these things because incidentally in Uganda, you find a media person is a trader or a trader of all jacks. How do they call it? A trader of all jacks or whatever. But they cover most aspects of society. They cover transport, they cover politics, they cover, So when it comes to health is a bit of a different sector. If they tell you PPH, and then you also write, for example, in the news that today they launched PPH, nobody will know that. So for me, I think the Ministry of Health and all those in that space, they need to keep identifying the media people they can really train, maybe quarterly, so that people are, first of all, the media is able to understand. Now, secondly, the Ugandan media, for so many reasons, they have just taken over politics. it's politics from morning to evening. And therefore, these people you are telling about the politics, and I don't even know whether you're explaining the politics very well, but they suffer when they go to some of these spaces, or maybe the mothers, because there's so much activities that are happening in families. So you expect many mothers to, have children. So the media has, even yesterday on Voice of Lango, somebody made a call in a morning program, which was discussing about PPH, and fortunately I was recording it. I was video recording it. A caller said, "Why do you keep us in too much politics and don't bring these topics?" So you can see if the public really was to be given
You see,
more
Ronald, a journalist
Yes.
will tell you that number one, in the politics is where the money is, but number two, it is the politics that determines all the other sectors of the country. So do you blame them?
That's where the money is, but I don't know whether us in the media we can celebrate over dead bodies because we are going to pick the money and I'm passing over dead bodies. Secondly, I agree with you that the politics determine the money. But let me tell you, and I don't know whether the doctors are listening to me and others,
Yes,
our politicians stop promising that they will of their actions. It's not. And the other thing me I would take on Parliament is that I think the current speaker must also change the way they are distributing money. And I'm told that apparently, and again, as you are saying, sometimes when the politics goes wherever it goes, this time round, we are seeing Parliament being the one determining when the budgets come. The Parliament is the one which is determining what is needed first compared to what the ministries are sending. And for me, there I agree with you, but still, if the media knew that aspect, that a minister of health will not determine the priorities of her ministries. And if you see the corruption tendencies that have been reported, this is where it starts. How do I bring a budget and you who is, yes, I know you are voting, the constitution allows you, and therefore, so for me, the media gets entangled there. They miss the 6 years. This 7 years ago, I chose to leave the politics and concentrate on health writing, not because of anything, but this is where life is. I spent in a hospital for 9 days with my wife who was sick, who had pet issues, that's preeclampsia. By the time I left, I was a changed person. I saw these people who are talking to us, the doctors. I think maybe, I don't want to go into religion and what, but they are kind of like second to God. You see people who bring back life. And therefore, the media must understand. For me, the other escape route, Philip, the other escape route about this is I always tell myself, if one day I find myself I'm a candidate of a hospital, of this healthcare, what will happen? What will happen? So we need to support the healthcare system, talk for them.
Thank you. Thank you. Good luck. Thank you. That's very powerful. And colleagues, what we talk about is a whole, he calls it an entanglement, or you can rather call it a paradox of a lot of things that jeopardizes the lives of our mothers. And we know when you look at the statistics, the number of mothers we lose as a country giving birth after giving birth, and of course on the challenges of PPH, it is a very, very large number, which I personally think can be reduced or even done away with. And the medical people have told you that if we behaved a certain way, we could have saved a couple of mothers who are no longer with us, whose maybe the children survived and they had to go through a very, very tough time. And I think indeed at such a point, it's prudent that we have a moment of silence in respect to the mothers that have lost their lives in a line of bringing life to the earth, but did not make it because of PPH. Yes, may the souls of our mothers that have lost their life in line of bringing life and because of PPH rest in eternal peace. It's painful, you will allow me. Thank you so much. Now, colleagues, as we talk about the healthcare system, we have a series of things in the country that contribute to this. And what I want us to focus on here is earlier, Helen talked about the numbers. She tells you if someone is not ready, you don't have the numbers to give all the time to teach and to address all the challenges that arise in that particular space where the mother is in labor and they have to be attended to, and there are very many of them, and the health workers are few. And then we have a country where people have gone to school, and to be specific, in the medical profession, they have to be deployed by government as interns. And government says it is not ready, it cannot deploy them at the moment. I want to start with you, Helen, where you are at Mulago. First of all, what is the experience like securing the deployment as an intern, but also what does it mean for one to finish medical school and they cannot be deployed in time? Helen.
Thank you very much. So your first question is, what is the process like in trying to secure an internship? First and foremost, I would like to say it's very agonious. First of all, there is no process to secure internship. By virtue of the fact that you got into medical school and you were enrolled in Bachelors of Medicine and Surgery, Bachelors of Pharmacy, Bachelors of Nursing, and Bachelors of Dental Surgery, you are entitled to a mandatory 1-year internship and thereafter get a practicing license in this country. That is just the eligibility. So there is no process to seek for internship. Yes, it's sort of, I should say, an entitlement of sorts. But what I'm saying is agonious is recently we've been seeing that Ministry of Health claims that the numbers are many, that the numbers of interns that are waiting to be deployed are very many. And then they say that their budget is not sufficient to cater for all the interns that are waiting to be deployed. Yes. So after finishing medical school, you're in dilemma. First of all, you have to sit and wait for like a year before you actually get into internship, of which you're not even sure you're going to get into the internship. Why you have to sit and wait for a year? It's not supposed to be like that. But it's because our predecessors also had to fight to be deployed with pay. Yes. So in the fight, the pulling of ropes with MOH, pulling hashtags, deploy interns with pay medical interns, there was a lot of time delays, right? And remember, whenever people finish school, they have to enter in one cohort for 1-year internship. So that means when you finish school, you have to wait for the current cohort of interns to finish their 12 months before you can actually also get enrolled. You understand? And on top of waiting, now it's even no longer a guarantee that you'll still get onto the internship list. Why? The numbers are many, as Ministry of Health claims. So for currently in my cohort, this is the current cohort that has just started internship. As per the statistics I have, were 2,541 interns waiting to be deployed. 2,541, yes? So the first list comes out and 1,435 interns have been deployed. Sitting for a year or two. Where are the rest? So MOH comes and says, this was our budget and this is the number of interns that we could take up, right? So they told us that they took the graduates of 2023. You understand? Remember, each year there are so many institutions that release cohorts of graduates. So this time they only took graduates of 2023. And by that, I don't mean all. I mean graduates from MBCHB, that's medicine, pharmacy, dental surgery. Nursing, there were only 5 nursing interns who were deployed from the country on the first list. Only 5. Graduates of 2023 have not yet, yes, 5. Have not yet even come to 2024. Wow. Right? So I told us that they can only take 2023 because we've been sitting for a year, and so the rest should wait. right? So now, the nurses are not on the list, even from 2023, right? You have deployed pharmacists, doctors, and dental surgeons. Who is going to be interning in for the roles that nurses need to fill up? You understand? So now, even finishing a course in medical school is no longer a guarantee that you will feature, that your name will feature on the list. And it's very torturous to wait. You remember you do a course of 4 to 5 years in medical school, and then you have to sit for 1 year. After sitting for 1 year, you're not even sure if you're going to be on the list. So where am I taking you? Now, you see how Ministry of Health says there's backlog and backlog and backlog? As I conclude like on your question, I just want to give you one case study. When you look at pharmacy, that's the course I'm in. Initially, there have been only 3 institutions offering pharmacy. That's Makerere, Mbarara University, and KIU Ishaka. Right now, there are 4 other universities that have been just accredited to teach pharmacy. That's KIU, that's Gulu University, Finns Victoria University, and I think the 4th is Busitema. I'm forgetting the 4th, but Finns, Gulu, Victoria have all been accredited. I want you to know that, remember, public institutions, for them, they do have a cap on how many medical students they can take in, depending on their resources and facilities, right? And that's Makerere and Barara, Gulu. And you look at the rest, KIU, Finns University, Victoria, those are private entities, right? Science is an enterprise, so that university is a business. So for them, as long as you can afford their fees, you will get enrolled in the course. You understand? What am I trying to tell you? The numbers are very many, and they're not even going to stop now. They're increasing. So if MOH claims that there is backlog and they're going to keep taking only those that they can manage to ably cater for, they're not accounting for the fact that institutions are getting accredited every now and then, and the numbers keep increasing. So the question I pose in my mind is, what plan do they have for the fact that the numbers are actually going to double in the next 4 to 5 years? Because there are more institutions that have now come up, right? Are we going to have more interns sitting for 2 3 years just because the budget cannot, accommodate?
Helena,
Yes.
You see, I completely understand your point, but also we need the numbers. Because I mean, you keep saying that the ratio of patients to medical professionals in the country is very low. I think something like 1 to a particular number I've forgotten, but we need the numbers, not so.
Yes, we do, very, very much.
Then maybe the ministry is right to charter all these other institutions to give us the numbers. Maybe we can address this as we build on the process. I don't know, but that's something we have to think about as the country. I want to bring in Dr. Ndahura. Doctor, you see, you listen to what Helena says and how the backlog I think Ms. Nguzi, I don't know whether you're saying something, but your network is not so clear.
I wanted to make a small contribution, something to tell you about the ministry in charge of health. I mean, they are the ones in charge of teaching. So I think Ministry of Health receives. That's what I wanted to make a clarification for you.
Well, thank you so much. Doctor, you see, when Helena tells you that they've been seated for a year, and we know there was another strike from the cohort that has just completed their internship, there was a strike, they had not been deployed for a year or so. And these are people, like she said, that have gone to school for the last 5 years, done a lot of education, parents paid a lot of money, government spent a lot of money to educate them in the public institutions, and they are not deployed as interns, not even as yet professionals. What does this mean for the medical career, especially for these young people who come out so passionate about this profession and they want to, and indeed yourself, what does it mean for you to see that people who are moving in the same line, in the same step, are not getting to the stages they have to get to in time and perhaps in the right manner they have to do?
It's a tricky part because we need the numbers, like you've said. But while we say we need the numbers, actually we don't get the numbers, but the numbers are there lying idle somewhere in the village, in the diaspora, in the brick making. The numbers are there. They are not actually where you need them. Reason? Reason, there is no platform to accommodate the numbers. Let me quickly give you an overview of how we utilize the numbers, or where we should have utilized the numbers. About a year ago, the Ministry of Health passed a structure that a health center 4, a health center 3, maybe if I say this, just to quickly let you know about the healthcare system of Uganda. At your village, where you come from, where your house is a village level 1. That's where we have a VHT. After that one, at the parish, there is a health center 2. It's a dispensary. At the health center 3 is at the sub-county level. And that one, we have a health center 3. It can admit mothers that are going to give birth. You get? So that one is supervised by a clinical officer. Clinical officer is a diploma medical trainee. Many institutions train that. From there, we have at the county level, we have a health center 4. That one is run by 2 doctors and the clinical officer and others. There we do C-sections, what we call surgeries. We do surgeries. We can remove a child from the mother through surgery, which we cannot do at health center 3. From that one, we got the district hospital. Depending where you come from, a district, among other things, it has a hospital. Then from there, we go to the regional staff, things like referral hospitals. So me, I want to stop at district hospital. So the government made a structure that we are going to have doctors at the health center 3. The other place where I said mothers can deliver, but direct by normal delivery methods, not surgery, not a C-section. And remember, that's where I was talking about things like PPH. We are from PPH now. Because if that person fails to manage a mother, it means they have to send them somewhere. So in a way to improve health, government thought we can have doctors at health center 3, which means we can have the surgeries and make services affordable. Now, a year has passed. That has not been done. That was going to absorb, let's say, 2 doctors here, plus let's say a pharmacist or a dispenser, plus the many nurses, like that. Now that has not been done. Get those health centers, get those sub-counties in the district, multiply them with the number of districts we have. All of those health workers are seated. By the time they did that, those health workers were there. So those ones are seated. Remember, we still want them, but they are seated. Even now, we have those existing facilities that don't have the health workers whom they're supposed to have. They are somewhere seated. So the problem here is not that we need the numbers and we are failed to have them. No country beats Uganda in having the numbers, by the way. The numbers are there, but they are lying idle. So what we are thinking, instead of lying to people that the numbers are overwhelming, yet we know we need them, but what is failing is where to use them from. Why not regulate the training? Because the training is expensive. Families have lost land, people have committed suicide after failing to complete tuition, which they would have used to venture into other airlines. So why not reduce the training to numbers that are known, that are formal, so that I have assurance that me, James, if I got into bachelor's of pharmacy, I will finish, do internship, get employed. Why not have that? Because now you don't have this assurance. So what does it help me to go into a system where my outcomes are not certain? If we have things like corruption, do you think we shall end because we have such systems? Corruption will not end. So we need the numbers, but we need formal structures to accommodate the numbers.
Wow. Thank you so much, Doctor. I want to bring in Msinguzi. Msinguzi, if we have you, you see, when you look at this whole cycle of things, it comes back to the government and the politics we earlier talked about. So let's discuss the policy, because when you listen to the 2 medics here, they are telling you, yes, we need the numbers, we need to manage the training, we need the numbers in the hospitals, but they are not there, and they are idle. He talked about them being in bricklaying and so on. From where you pick information, and especially the ministry, why do we find ourselves in such situations where we cannot prioritize and plan effectively to see that our healthcare system, like you broke it down from the village health team to the national referral hospital level, why can't we plan effectively for these people and see that the deployments happen in time and the payments are effective and timely and all these other things? Why?
Thank you very much. I think for me also, the medics sometimes when they are blaming, they also need maybe some information. Budgeting is not done by, finally, the one who decides the money is not Ministry of Health. It's not like they have a deep hole where they pick the money. This money is determined by our members of parliament, but it also depends on what is in the national, whatever, in the national treasury. I think to go back a little bit, as you remember, there was an issue of increasing money from 600,000 per internee to 2.5 million Uganda shillings. And therefore, when the issue of money came in vis-a-vis the numbers, apparently that year there was 35 billion. And even you could find that sometimes that money paid, the first payment took to 9 months. So even when Parliament provided another 35 another year, they had first pay that people who had pushed up to the 12 months. So it became such a abuses on social media. But for me, I used to read them even now. I was like, I wish also these ones get the right information. You see, if you abuse a person who is not in charge, then for me, maybe it's like efforts are being directed to a wrong person. But then
Musinguzi, you're a journalist.
Yes.
If you allow me, you see, when you say they are maybe addressing their issue to the wrong person, no, actually, I would disagree with you.
I'm coming.
The Ministry of Health is in charge of managing the healthcare system, both technically and politically. They have a political head who is a minister. They have a political head who is a minister that sits in cabinet, which cabinet is responsible for cutting down the national cake into where it matters.
Philip, let me first talk to you on facts. Ministry of Health does not train health workers.
Yes.
And therefore, the next year, they don't know how many people are coming. Do you agree with that one?
No,
so
it's
Ministry of Education.
You see,
Ministry of Education. Yes. Ministry of Education.
The entities you talk about, Ministry of Education and Ministry of Health, are entities of government. There is no way we will tell that this particular ministry cannot get data from this particular ministry.
Philip, it's like the way we are on this Zoom.
Yes.
And maybe the network cuts me off. And then you say, but you are supposed to be on this. Sometimes, yes, talking is one way, but dealing with these things, these are challenging things. But let me go back to the point of where I was saying the blame should go. For me, it is Parliament that decides where the money. And I was giving, and I wanted to finish this point, that when the 35 billion became less and Parliament was not increasing it, eventually Parliament sat and reduced the money from 2.5 million to 1 million. And the last cohort got 1 million. And like Helena is, if she can affirm, they are going to be getting 1 million shillings. And therefore,
yes,
the Ministry of Health has gone to Parliament and said, can you give us money according to the numbers the requests we have? Let that be the budget, or let the budget be incremental. But Parliament has not provided the money. And therefore, for me, I don't deal again in hazy things. I'm saying Parliament and the Attorney General said.
Thank you, Mr.
Attorney General said we need additional 18 billion this year to take over all the numbers of interns who have been kept and those who should be going. But the question is now, either as they go to Guru, wherever they go, somebody needs to focus on members of parliament from wherever they are. We are all from different constituents, have members of parliament, priorities, the medical, interns, provide the 18 billion on top of the 35 billion, so that these young people who are needed, like everybody has said, and me, like also I said, that these are people who are next to God. We need them like.
Thank you, Musinguzi. Thank you, Musinguzi. And I agree with you, except on one issue. In my opinion, you see, I'll give you a very recent example. You know, the president refused to sign the appropriation bill of this new financial year, and it had to be brought back to parliament to reinstate certain expenditures from where the members of parliament had sought them to be to where the president and indeed the cabinet wanted them to be. And, you know, a series of things were changed, including getting monies, for example, from buying of ambulances to finding money to bail out robo construction company, getting money from schools to there is an investor who is putting up a certain farm somewhere, you know. So basically what I'm saying is cabinet and indeed the ministers headed by the president have a higher and instructive role in terms of how these resources are put to whichever sector. And also, you know, that we are running the Manifesto of the National Resistance Movement, which manifesto is a preserve of the NRM, the president and his ministers, and indeed the party, but also the National Development Plan. But that's a subject we can discuss on another show maybe later. I want to bring in Helena briefly. Helena, I want you to help me talk to one, the emotional, the mental health, the psychological, and the morale of the interns, those that have been deployed, but also those that actually did not get the opportunity to be deployed, especially the mental health. How does this whole situation work out with them? Aren't we going to have challenges of people who are mental unstable?
Thank you very much for that question. But before I answer that, I would just like to clarify myself on one thing. I do not challenge that government or NCHE charters private universities. You see, when you say we need the numbers, I want you to understand and hold your statement to the lens that this is a medical field. We don't just need numbers. Before numbers, we need quality. Quality first, then numbers. The numbers will be useless if the quality is missing. So I wanted to just clarify on that. I'm not challenging NCHE's decision to charter private entities, but I'm only seeking to challenge the eligibility criteria about how they accredit the universities. And for me, I do not agree that we just need numbers. For me, it's quality first, then the numbers, because this is a field where we deal with life, and that is not to joke about. Yes, then to go to your question about the mental health, the truth is, personally, I have been deployed, but I want to speak as someone who has not been deployed. Yes, we are not okay. We are not okay because we spend a lot of time in medical school only to come out and have 1 year, or even actually, if you're lucky, you'll have just 1 year of stagnation professionally. But the thing is, there's even a promise of more years as long as the numbers keep increasing and for as long as the budget cannot cater for everyone's needs. Yes. So I want to say that the mental health for all those who have not been deployed is actually doing very badly because, one, you're very anxious and uncertain about what next. You're asking yourself, what next? Your parents know, everyone knows you've graduated. Even before your parents, actually, you yourself, you know you've graduated. Yes, you can get a gig or a side job or you know, but then the thing is you need your license. And for you to get a license, you must go through the 1 year mandatory internship. You understand? Also, I want to speak to the fact that whole year of waiting, it's a very rigorous year because you're not even sure about whether to take on a master's or not. you don't have a license in your country. So what happens if you actually want to take on a master's in another country? And then when you come back, you have to resit for the licensing exams in your own country when probably some things have changed, curricula have changed. You understand? You're not even sure whether to apply for a master's. You do not know what to apply for because you are waiting for that list. And then when the list comes out, it also has a second list where even some people could potentially be removed from that list, by the way. You're not even sure if you'll get on. So it puts one in a period of professional stagnation. And the problem is very problematic because you don't even know how long the period of stagnation is going to last, because it's not even a guarantee that you're going to sit for only a year. And I want to add on, I think there is a point Musingozi was trying to build. I don't know if I misunderstood him, but the thing is, when you look at the budget, Mr. Philip, I want you to put yourself in the shoes of a government stakeholder. Yes. The thing is, yes, you make your planning, you do budget allocations every year, but will there always be money for the numbers that you even never know will come in years to time? Do you think you can bank on the possibility that you always get the 1 million shillings for everyone who enters medical school? No, that's definitely I know, because you do not know how many private institutions are going to take in. So you have to ask yourself also, to what end will this budget keep being expanded to cater for everyone? So I want to propose a very sustainable a solution, Mr. Philip. I know I'm getting into another question, but kindly allow me to.
Okay.
I want to table a very sustainable solution. The thing is, we do not want to be into medical school. You do 4 or 5 years, and then you sit 1 year waiting for internship. You're not there. 2 years, you're not there on the list, and then there is more backlog. Yes. So I want to suggest, if there is no guarantee that Uganda will ever have money to cater for all the numerous interns in the future, in the near future to come, or even now, before even going to the future, let there be a cap on the number of people who enter private institutions. Because for me, I do not agree with the statement that we need the numbers. It's not about numbers. The numbers are necessary, yes, but primarily the quality matters, because this is a very delicate field. I want to promise you, we don't just need numbers. It's about the quality of the numbers that are coming in. And then to add on to what Dr. Elikana said, quality first and then the numbers. So when we have the quality numbers, then we can actually look into government putting in place institutions that can absorb the quality numbers. Yes, that's my stand. Thank you.
Thank you so much. Dr. Elikana.
But like, to go back to your question, the mental health. Yes, you can continue.
Thank you so much. Dr. Elikana, briefly, you see, professionalism in this country is growing, and we know the other sectors. You talk about the legal profession, now we are discussing the medical profession, the engineering profession, and so many other professions. You have people in the back, in the primary schools, in the secondary schools, that are looking up to their elders who have, like yourselves, who have gone through the school, and you are now called a doctor, you are called a pharmacist, you are called a lawyer, you are called a journalist. What does it mean when you see such complexities around the deployment of interns, and even those that have finished their internship cannot find a job easily? What does it mean for the young people who are studying down there still in the science and the biology, who look up to joining the same profession? Dr. Rekana.
I want to categorically make it clear that that might not have much impact on young people going into the medical school, as long as it's their desire, but also if they have good mentorship. My school of thought is like this: no one at any one point should ever restrict them to working in Uganda. That's my school of thought. That's me. I have never looked at myself as someone fit just to work for only Uganda. I think I can do work and thrive in all the countries that we have around the world. But also, it's something to know that despite this is suffering, I will call it suffering, if you ever have a passion to serve in this healthcare side, then you will serve. That's 2. It's about perseverance and persistence. And then 3, we know that all this will end. At one time, we shall have clear structures where people listen, where people do things that are genuine and honest. Remember, I'm saying this from one side of the coin, that whereas it is the Ministry of Education which decides who trains what and who enters, the Ministry of Health is a stakeholder there.
Yes.
It has someone there. And actually, it has a big say when it comes to, because education is big. It has arts, humanities, law, it has health. When it comes to health matters, there are very many health workers that are stakeholders in the Ministry of Education. That's one side. 2, other institutions
Maybe
like
for information, for the Ministry of Health to give a license to any institutions to undertake a medical course, they must have approval from the Ministry of Health.
Yeah, they consult. Yeah, they consult very well, because even these other bodies like pharmaceutical society,
the law doesn't. Factually, the law doesn't allow that. It's the Ministry of Education. I think let's give information which is clear.
No, good luck. Good luck, please.
Unless you change the policy or the constitution for now.
No, good luck. First, wait. I hope you understand the composition of the technical working group of the Ministry of Education that participates in decisions that affect healthcare. Things to do with school curriculums on health, school adolescent health programs, the training of the medical institutions. I hope you know the technical working group, because it is there. It is not the air. The committee is there.
Yes.
You know that. So the law, whoever signs the law or whoever approves is the Ministry of Education and Sports. The way the president signs the bills. The bills are first discussed by the parliament, but the final person to sign is the president. So the final person to sign these things is from the Minister of Education and Sports. But the stakeholders, the actual stakeholders, the majority of them are from the Ministry of Health, National Council for Higher Education, and these other bodies, Pharmaceutical Society, Uganda Medical and Dental Practitioners Council. All these are led by health workers. And they always put their decisions clear, and they have always brought policies. We have a doctor who has been leading the Parliamentary Health Committee. The decisions have always been submitted. But these ones always end at a certain point. They are not considered, because we know the repercussions of what happens. So it is not that these things are not being seen. They are being seen, but there's someone above all this. And I don't like speaking from the political perspective. I like speaking from a civilian point. A civilian point, but also from a technical point, because I know the committee and I know people who I can mention names of people who sit at the committee.
Thank
so
you,
I always
Doctor.
want to be honest.
Yes, thank you, Doctor. And indeed, the journalist will do a little more. I know he has access to that information. Now, colleagues, unfortunately, our time is very much fast spent. We have about 5 minutes to close out on this show. Now, I'll give a minute and a half to each one of you to give us your concluding remarks about the topic at hand, the interns, but also the PPH issue and how we can move forward progressively as a people and as a country. I'll start with you, Mr. Musinguzi. Good luck, Ronald.
Thank you very much. Today in the morning, there was a national Zoom which I attended on PPH. The numbers from what the commissioner was saying, they are compiling something that shows that these efforts of awareness are going to be good. The numbers might reduce, and therefore the media and civic space TV, if you continue also as a way of promoting also human rights for us to be alive and for others, if you continue adding a voice, I think this one is very good. terms of the interns, like yesterday, lately, I can tell you that the issue Helena talked about, Ministry of Health has had to spend a lot of money to mentor people because the quality issue she was mentioning. And thirdly, I'm also aware of the push and pull of the Ministry of Health and Education about who should take charge of this so that we move as a country. And for me, also the media, let the media, every day, we have 24 hours. While you give us music, while you give us, what is the Lugambo, the politics and whatever, include the health tips that helps our mothers, that will remind our mothers of their role. And lastly, the men. Let us, the men, let us be involved. There is no way we are going to make people pregnant, spend 9 months without saving something little to really, if you love somebody, if you really love somebody, start saving for that pregnancy so that you support. And as we see the bill of health insurance come this time of parliament, I hope it comes so that all of us make some contribution and we have enough resources, support these doctors. And as I said, they are next to God. I've seen what they do. They are great people. Thank you very much.
Thank you so much. And indeed, you talk about the health insurance bill. It's been there for a very long time. I hope we're able to have it done this time and signed into law. But thank you so much, Mr. Musinguzi Ronald. Good luck for the amazing views and giving us your time. Dr. Rikana, your final remarks.
Thank you once again. I just want to ask all of us to be ambassadors of this word. Let's spread the message. Whenever you get an opportunity, speak the message to the media, people on TVs, radio stations. Do not make healthcare costly. Don't ask for doctors to pay to educate communities. Once in a while, invite the health workers, speak to the people, give them a little airtime. 20 minutes are enough to say a few things and they go. Not materialize everything into money, because people in healthcare will now give you money for their other businesses. And of course, to the health workers, for us, we are going to do our part. But the rest of the part is for the community to get interested in health matters. I can assure you, the more you don't understand health, the more you will suffer. Because if we tell you that you need to screen for sickle cell and you do not want, when you get the sickle cell child, life will be hard. So it's us to, the way we interest ourselves in different matters, like politics, the way we should interest ourselves in healthcare, and then life will be good.
Yes, thank you so much, Dr. Rikana Ndahura, for that really good advice and for the amazing views you've given us. And last word on the show is pharmacist Helena Angela Nagawa. Helena, your final remarks on the same day.
Thank you very much. I would like to put a different twist to all the recommendations of TEBOD. I had suggested that a cap be put on private entities. Yes, that is also still a solution. But I want to put a twist to this conversation. It is not fair that someone gets enrolled in a medical course into medical school, spends 4 or 5 years, and then they have to sit down at home in a period of professional stagnation, anxious and very unsure about what they're going to do about their future. So I want to challenge your minds, to all the people in this space. With all the billions of money that we see that the parliament spends every day, I still think this conversation, yes, it could be about the numbers and everything, but I still think if government has its priorities right, starting from budget allocation to the most critical sectors of the country, if we are to channel those resources that Parliament uses, those resources that are allocated to Parliament, yet Parliament shouldn't really be a priority, because when you look at that budget, it's so big, right? that money can actually cater for all the numbers that we have in this country. Because when you look at the money that they, use every day, oh my God, like your heart can literally break. But yes, my 2 cents as I end this conversation. One, I still think in as much as MOH may not necessarily know the number of people that are coming into internship, the ministries, yes, they work independently, but they should work together because they're serving the same government, they're serving the same people, right? Why isn't MOH communicating to Ministry of Education and Sports to just get basic information as far as the numbers are concerned? How are they working independently, yet they're working towards a common good? One. Two, I still think yes, I want to challenge the fact that we have private institutions in place, but I think it would be more sustainable if government can put a cap on the number of people who get enrolled. It's easier to regulate from the start as opposed to giving someone false hope. They come into the course, they study, and then at the end you're telling them they cannot be absorbed for internship. So where are they supposed to go if they do not have a practicing license? Three, I still want to re-echo that point. The money that goes to Parliament of Uganda every day is still sufficient to cater for the overwhelming number of medical interns that we have in this country. And then for Mr. Philip, one of the things that you haven't gotten from any of the speakers on here is about the criteria for selection. For internship, I told you that by virtue of the fact that someone is enrolled into a medical course, they are I want to call it an entitlement. They are entitled to do a 1-year mandatory internship, right? But when you look at the recent proceedings that have been happening from MOH, right now there's going to be an addendum list to our list, and they say that there are 121 slots more. But then when you look at the criteria that they're using to select people who are going to fill up the few slots that are remaining, they're saying that they're going to consider people who are in government. They have put pharmacists who are on government scholarship. And then I'm thinking, okay, someone got enrolled into a medical course. Why is it that you're considering someone just because they have government sponsorship as opposed to someone who also enrolled and did the course? Why then is equity and equality? Why is it that I should first and mostly qualify for government scholarship before I go into internship? Where is the rationale? Where is the rationale? Yes. But otherwise, thank you so much for having this conversation. And I think the last thing I would like to say is medical interns deserve to be deployed. And the truth is, hospitals, especially public hospitals, are so understaffed. And the truth is, those hospitals run on the labor of medical interns. And Mr. Philip, I actually want to tell you that even that 1 million that we are receiving, when you look at the workload that we have, oh my God, I think we are being underpaid. Not that I think, it is the fact that we are being underpaid because the workload that we have in those hospitals is so heavy. So yes, I will still stand with the interns who have not yet been deployed, that they should be deployed. And I still think that Parliament should reconsider the billions that are in their coffers to fund the pay of medical interns. Thank you very much.
Very painful realities there. You mentioned the underpayment, the workload, the criteria, and so many others. Very painful, and we hope you colleagues who are listening in from the Ministry of Health, I know we have a couple of you from the Ministry of Health, and by extension, the entire government structure can pick up some of the ideas you've listened to here and see that we have better ways of addressing these issues such that we have a progressive society. Thank you so much, Helena Angela Nagawa, for the amazing views, but also for finding time to speak to us here. Thank you so much, Dr. Rikana Ndaura, for finding time to speak to us and for your amazing views. And Mr. Musinguzi Ronald, good luck. Thank you so much for the amazing views, for the information, and finding time to speak to us, and indeed to you, the audience. Thank you so much for keeping it Community Voices on Civic Space TV. Special thanks to the Center for Constitutional Governance for the amount of work you put in to make sure all these are possible. Special thanks to the people behind the machines. We appreciate your technicality and the skill you employ to see that we have this pooled of funds. Special thanks to everyone that contributes to the success of all these partners and friends and everyone who work with from us. We say good evening and may you have freedom always.